Okay, good afternoon, friends in Ethiopia. I just wanted to welcome everybody again to our last panel of the session on COVID-19 that we have been undertaking since, now 3 weeks. As we are waiting our part of our panelists to join us, I just wanted to go over a couple of things that might be useful to think about what we call preparation towards this COVID-19. And this is something we undertook within our Department of Surgery in trying to get everybody ready for it. But it is also something applicable, I think, for the hospitals, and at least it's really applicable in the thought process in general, from individual level or departmental level, or even higher up. So there are a couple of things that need to be defined first. One is there is what we call conventional standard of care, and this is basically a situation where the space, the staff, and the supply we use are consistent with our daily practices and the institutional guidelines and standard of care. So meaning this is the highest standard of care that we require and abide by. And this is what we call conventional, because this is what we have on a day-to-day basis when we are not constrained by emergencies or crises. The second state of function is what we call contingency standard of care. And contingency standard of care is a situation where the space, the staff, and the supply are not necessarily consistent with the daily practices, but we try to do our best in terms of providing an equivalent standard of care for patients that are coming our way. And that's called contingency because we are kind of upping our game. And I know our situation here is kind of fluid between conventional and the contingency standard of care, but it is also important to understand that you have to be flexible. You have to really continue to strive for a standard of care that is acceptable to you, follows guidelines, and stretch your resources as much as possible to stay in this contingency situation. However, when things are really, really difficult to maintain that standard of care, and you are, and there is a lot of, overflow of things that you cannot control, that is when you basically get into the crisis mode. And that's called crisis standard of care. This is something, for example, you see in time of war, where you don't control how many wounded are going to come to you, or in times of cholera, for example, or in times of any other major epidemics like the pandemic that we are facing now, where you can really get overwhelmed. In those situations, your adaptive spaces and your staff and your supply are not going to be enough, and so you have to really think about fulfilling your responsibilities by thinking outside the box. In doing so, you have to really put some strategies in place. And these strategies that you put in place are usually in this 4 or 5 categories. These 4 or 5 categories that you see in terms of prepare, it is really important before getting into the crisis, if you can anticipate, number one, you try to prevent things from happening. Number 2, you start basically saving things and preparing by stockpiling some of the medications you need, or in this particular pandemic situation, for example, by making sure you are collecting your PPEs and using them, responsibly. You have to also think about substitute, because sometimes you run out of drugs or medications. And if you don't have morphine and you have fentanyl, then you need to use fentanyl instead of morphine, or for that matter, any other pain medication you may use. And so in general, thinking about what if I don't have this and what can I use in replacement is really one other strategy that you have to think about. And when you are faced with this crisis situations, adopting is really another important aspect because think about if you don't have enough ICU beds, you can maybe adopt by using your recovery area or recovery space to become your ICUs because there are ventilators in there, or you can also adapt basically by using the ORs to be the space where you want to be ventilating these patients and making the OR itself an intensive care unit. So adaptive strategies are important. And the other two are conserve and reuse. And think about, we talk about this in the context of N95s, for example, where you don't have enough of those N95s. And in those situations, you can always have a strategy to reuse them, to cover them up with another mask and reuse it. And also, in times of, scarcity, that's where innovation kicks in. And you may come up with a lot better ways of innovating and taking care of business in a way that that can conserve, and also you may create some innovative ways of reusing things. So, for example, if you can see my video, I have here what we call a face shield, and this face shield was printed, within few days by our biomedical engineering department, and they produced 1,000 a day out of plastic, and there's a little bit of a foam here, and there is in the back a little bit of an elastic wrap. And what this is being used is as a face shield for almost every employee in the hospital. And it is reusable. We just wash it with the disinfectants, and we reuse it. So reuse and conserve is a strategy that you have to be familiar with and institute in these situations. So overall, in strategizing and trying to prepare yourself for these crisis situations, these are maybe the three big buckets of ideas and preparations you have to think about staff, about space, and about supply. I remind my colleagues here in Wisconsin, and also whenever I'm talking about global health issues, I always remind them saying we are always in a crisis mode in low resource countries. We are always in that situation where we have to adapt, we have to conserve, we have to reuse. We have to reuse a suture 10 times before we cut it off. And so I think in your situation back home in Ethiopia, probably this thought about preparing, substituting, adapting, as well as conserving is not something new. We just need to be intentional about it, and we just need to make sure we do it with some purpose. When it comes to staff, we talked about this many times, and it is really critical to make sure everybody on your staff is aware of what is going on. And everybody should be aware of what is an institution doing in response to the work you are trying to do. If there are some new skills you have to teach them, you need to teach them all those new skills. For example, how do you go in and out of a COVID unit? Basically what we call down and doffing. So putting on and putting off your protective devices. How do we do that? You have to instruct and educate the staff about PPE usage. Otherwise, it will be overused and you may run out of them. You have to really also understand and survey what is, every physicians, every nurses, and every other individual on your staff, what kind of skills do they have? Because sometimes you may have to overlap things. Maybe the surgeon may have to take over the ICU, or the internist may have to really tend to the critical care patient. And so it is important to know what kind of knowledge base everybody has. Some people may be good at doing tracheostomies than others. I mean, you have to really make sure you survey and understand the competency so that when you get into that crisis mode, you can use them wherever there is a need. And it is absolutely critical to think about which one are the core critical aspect of the workforce that we need for whatever crisis is happening. And so putting the staff that is working in your hospital in those categories and making sure they are educated, they are prepared, they are deployed in such a way that their expertise is used is absolutely important. The space, as you know, is another area where you can focus, and you have to focus because you don't know in terms of pandemics or other crisis situations, how many beds do you need? How many ICU beds are there now? And how big should it become? How can I repurpose the dorms, the hotels, or the rooms that are in the hospital to accommodate more patients? What kind of special equipments do I need to make these rooms to take care of these patients? How can I, within the region, work with the other hospitals or healthcare facilities and strategize to make sure I have flexible beds? You cannot really stay rigid without flexibility, even within your own hospital. Maybe you should be able to identify and say, hey, I am going to designate this space for these reasons. You have designated staff for that area. And so you have to really think through about the space issue with a lot of flexible thoughts. Last but not least of the essence is a supply. And understanding the resources you need is so critical, and you have to start that from the beginning, from the early stages of preparation, which gives you the understanding and the magnitude of what you are getting into. And therefore, you have to anticipate what your resource shortfalls are going to be so that either you adapt for those shortfalls or you substitute those shortfalls. You need to really put in place strategies to conserve the little supplies you have. And everybody should be on the same page. Everybody, I mean the physicians, the nurses, the dressers, everybody that is working in this area needs to understand the materials you need, you require, and you need to conserve. In terms of surgeries in this difficult stages of pandemics and crises, a lot of times may have to be stopped, any elective surgery, and you may have to really focus only on the emergency things because it can drain resources. And I know it's not easy to do that, but those are decisions that a central command or an authority that is created within your hospital has to basically take control of and give orders and make sure those orders are followed. So with that, the workforce can be deployed in such a way that is, not stretching them too thin, but also particularly in the time of pandemics, you don't want to deploy everybody and get everybody sick. So you have to protect a good amount of your workforce sparingly so that they get exposed relatively less, and you can conserve your staff as a supply. Just like the other materials you use, you can think about your staff also as a supply and use them in a very sparing way. So there are a lot of additional thoughts, be it in pandemics or other crises, that you have to really work around the three major topics of staff, space, and supply. But I just wanted to kind of summarize a little bit what I think Dr. Dawood had presented to you during his talk about leadership and how to prepare. I think all his thoughts probably distill into this few aspects of the staff, space, and supply. So I will stop there for a minute and see who from our panelists are available and ready to talk to you. And I know I've seen Dr. Mola and I've seen also Dr. Rahel. We can always start with that. So start inviting our panelists to summarize a little bit their thoughts from the last time, and then we will go into the question and answer session. So I see Dr. Putsum. So let me start with her. Hello, good to see you. And so the way we wanted to run this was maybe you can summarize the important things you think from your last presentation in a very short time. And then we will go to Dr. Zerihun, Dr. Mola, and then Dr. Rahel, and then we will open up for some questions. So let me give you the floor, Dr. Putsum, right now.
So I may say the same thing that you already said. So from what I said last time is when preparing for a COVID epidemic, you need first to think about your ICU capacity, which is a limiting factor for most hospitals here. Think about triage and have clear trajectory to identify the units that will need to be transformed into COVID units and non-COVID units, depending on the geographical position and so on, because the patient should not cross or cross-react with COVID negative patients. You need to reorganize all the resources and health workers' schedules, have protocols, and when reorganizing, you need to have two main targets: save human resources, so protecting the health workers and limit their exposure, and save resources also, limits all the non-essential health workers or staffs and their exposure to COVID patients. When taking care of COVID patients, one main thing that I wanted to remind is that you need to have advanced care planning with level of care, because for some patients, you will need to have to plan palliative care, because the severity of the disease compared to the comorbidities and the patient preference also might help direct him to into palliative care. You need to anticipate the level of care, but also anticipate signs of deterioration. So if a patient needs to go to the ICU, he needs to be referred very early before having a cardiac arrest or collapse. I wanted to emphasize last the emotional impact to the patient, to the families, and to the health workers, because taking care of COVID patients is stressful for the health workers, but also the patient doesn't have all the support from the family, and visits are restricted. So it's a big emotional impact, and that needs to be addressed when taking care of COVID patients. And that's it.
So thank you, Dr. Putsum. And I see Dr. Mola. Dr. Mola, any thoughts and summary of your presentations, and how were the past week and a half for you, and any new things you learned?
Thank you, Dr. Gurma. I would touch some points on my last talk. It was mostly on the, clinical care part. So I talked about last week how these patients manifest from the beginning all the way to intensive care unit. So, and as time goes, we're getting more and more experience. We've been hardly hit, the place I work for the past 3.5 weeks now. Currently, we have about 123 patients with COVID. From this, we have 34 patients in ICU, and 28 of them are on mechanical ventilation and full life support.
Oh.
So, so yeah, it's so we have two floors of the entire building restricted for COVID. So as Dr. Fusum said, no one, and then there is another area that's called the place for PUIs. We call them PUI, patients under investigation. So those patients, for example, should not be, we try not to mix those patients with patients who are already positive or patients that has nothing to do with COVID. Because if you put those patients into the COVID unit, some of the patients have multiple comorbid issues and they can easily catch the virus from healthcare workers or other patients. So we have kind of three separate areas: non-COVID unit, a unit for PUIs until the test results come back negative or positive when they come back to the COVID unit. So in terms of preparedness, I think this should be put into consideration. But going into my talk, as I said last time, these patients understand that there would be about 20-25% of patients who are infected and would remain asymptomatic, and they're in very high risk for disseminating the disease. In those who become symptomatic, about 80% of patients on average, there's different data, but generally 80% do well as an outpatient. So they need to have some supportive care. They could have some antibiotic treatment for possible concomitant bacterial pneumonia, medications for fevers, in pain and things like that. Then about 20% of patients require hospitalization. Most of them can be managed in the general medical floor. We have almost routinely been giving them antibiotics for pneumonia until cultures come back negative, as well as hydroxychloroquine. There was some data that came out, I think from France, that suggested that combination of macrolides like azithromycin and hydroxychloroquine had a good benefit, but there was another data that completely negated it. So you have to be careful that both medications can prolong QTC and can lead into fatal arrhythmias. Especially, we know that these kind of patients can also have viral myocarditis, pericarditis, and they're already susceptible for this kind of arrhythmia and death. So that combination is not routinely recommended, and I think we've stopped that practice here. The others, in terms of medications, we routinely give them vitamin C and zinc as well. Again, data is very sketchy, but we're throwing everything we can. When it comes to antiviral medications, there is a very promising preliminary data that's coming out of University of Chicago that a medication called remdesivir might be good, but it will take some time to get that going even in the Western world. So that's probably not a very realistic goal for a situation like ours in Ethiopia. The other thing that we've been trying and have seen some, it's obviously anecdotal, but we've seen quite good responses, IL-6 therapy. There's this concept of cytokine storm, patients with very high inflammatory state. We check D-dimer, CRP, LDH, ferritin levels, and we set up criteria based on those small studies that we have. And we tend to select patients who we think have cytokine storm, and we've been giving IL-6, anti-IL-6 treatment, a medication called tocilizumab. And here we've seen quite impressive outcomes to be, again, it's not in any way supported by a study, but we've seen patients defervis quite quickly and come off ventilator support. So that might be a good thing in the future, but again, in Ethiopian context, I think it's super expensive and it will take time, so that's not realistic. So when it comes to management of patients in the Ethiopian context, again, the most important thing is focusing on prevention, isolating those patients, protecting staff, and routine supportive cares, oxygen through oxymask or nasal cannula. To my knowledge, high-flow nasal cannula is not available in Ethiopia. It needs pressurized air system in this. I don't know non-invasive ventilation is available, but again, that's also not recommended routinely because it can aerosolize and expose staff and other patients. especially in Ethiopia where negative pressure rooms are not available. And it's mainly focusing on supporting them with oxygen, giving them treatment for possible concomitant bacterial pneumonia, use chloroquine that's available while looking for side effects. Usually, arrhythmia, QTC issues, liver issues, GI symptoms are the common side effects. Probably the physicians in Ethiopia know much better about this than I do, because we use here hydroxychloroquine and not chloroquine. And then as the disease progresses, transfer them to ICU, consider safe and early intubation by the first available, the best available expertise. In the Ethiopian context, it might work better if we just set up an airway team. Anesthesia people in Ethiopia are those trained to manage airways at this point, because I know that critical care physician resource in the country is very limited. And see how things go. Again, try to disseminate, try to prevent dissemination of infection in the healthcare setting. Try to protect staff. Try to train staff with appropriate donning and doffing of resources. Also in planning. So in here, we've not been overwhelmed, but we prepared for something disaster. We have set up what we call a mass critical care triage program. If the patients were to go up, we're at 60% of capacity. For example, if we were to reach at 90%, we have prepared a plan for appropriate rationing of resources, because you can't take care of everybody. We have set up what we call a Triage Committee, a blinded independent group of 5 people who can look at the patients and try to allocate resource for the patients who can most benefit from the care we deliver. If the person has, like, in 80s, a lot of comorbid issues, for example, and they're young people in 40s and very sick, so we tend to, we have set up criteria. So I think the hospital systems there need to start setting up committees and preparing for something like this. Hopefully we don't get there, but it's always good to be better prepared than get overwhelmed when the things come. I will stop here, and I think I will let more time for question and answers.
Great, thank you for the summary and some of the new thoughts and ideas. And it looks like your place is, by comparison to many, getting overwhelmed. They have pretty sizable amount of patients. So I think it's probably important to think about, maybe later on, Dr. Filsum, if there are some thoughts about who can be treated as an outpatient kind of guideline. Maybe that's something to talk about, and we'll circle back to you. But in the meantime, I see Dr. Zariun is online, and I know, Dr. Zariun, are you by phone or computer? The floor is yours if you want to go ahead now.
Thank you, Dr. Gurma. Good morning, good afternoon, everyone. So this was nice to come here again. I think just to give about some updates about, maybe summary about my talks and, what has been happening here in St. Louis. St. Louis, in the last week or so, we kind of are seeing the slowing of the cases. I think the social distancing is probably, I believe, is working. We are seeing more patients going into the chronic phase. I had several patients who has been on a ventilator for 3 weeks or so. And unfortunately, these patients are in a state where they, I think, where you can say they're not really alive. In what I meant is they are really severely devastated by the infection. And I was kind of thinking of towards, tracheostomy, chronic ventilator, feeding tube, and so on. The problem is tracheostomy itself is a very challenge. Typically tracheostomy we do at the bedside, and using bronchoscopy and so on, but that's out. So it has to be like a surgical open tracheostomy, and the whole OR has to come to the bedside. The ventilator has to be paused. So all those logistics are on process, but everything is difficult. So we are thinking thoroughly about how to do that at the bedside. So that's another challenge. So every phase will come with a challenge. Ventilator comes with actually a heavy challenge than what you can imagine. So that has been being suppressed. So I think the other issues we're facing in our hospitals was the PPEs. So that has been challenging, and we have seen it's like every day a lot of emails, every other day change and so on. The authorities are changing the recommendation based on the resources they have, how much PPE they have, and all other things. So we have to be really be prepared, and because PPEs are necessary, and we have to conserve them. We have to also give for the appropriate peoples. So I think there should be some planning so that a bad scrambling doesn't happen down the line. Unfortunately, in the U.S., this was a situation, and it's sometimes sad, but that needs a good planning. And I was amazed by seeing the nurses doing the job. I think they were amazing. They when you go into the ICUs, you see them, and you feel like, my God, is there anything different? Because really they are the most amazing support for this patient. They take care of them. They they have the PPE and so on, but they do take care of their business. They are the most exposed. They are the most who goes in and out. And it is amazing to see them. So I think we need to give a shout out and support to the nursing staff. They are the one who does a lot of the things. And we were able to find a way to take out the the IV pumps and poles. That has helped tremendously their entrance into their rooms. So I think that's if I say that about the hospital, and just to say a few stuff about my talks and so on. I think last time I talked about a little bit about the Cobe pneumonia and the ventilator aspect of it. I think, as we said, Cobe pneumonia is a very interesting and weird disease. Really, it's every day we are learning new stuff, and it's it is amazing. Its mode of transmission is kind of stealth. Many people are asymptomatic. They are the spreaders, and even not only that which is stealth. It is, once it gets into the body, our immunity usually takes time to recognize it, and when it recognizes it, it goes into this unregulated and severe inflammatory response, which tend to overdo and injure organs. So, if you see the Cobe pneumonia, I think from the knowledge we have so far, the injury happens in three ways. One, the virus itself, causes the injury. The virus, infects and, kills some of the lungs, the pulmonary vasculature and other organs. The second mechanism the patients get injured is, the unregulated, high, severe inflammatory response. So the inflammation itself is really causing severe organ damage. And the third way the patient get hurt or have organ failure is, it is the patient's self-inflicted lung injury, which is, they go into hypoxia, And to compensate for that, they start breathing harder, but they don't feel that dyspnea sense, because their CO2, which monitors are feeling of dyspnea, is normal. So, and when they do that hard breathing, they end up injuring their delicate lung tissue. So, so these are the kind of the ways injured. So I think, in the early phase, it's important when the virus was spreading, the antivirals may be a good point. Usually the antivirals are effective, mostly, if we call the patients in the early phase, because that's when the virus is spreading throughout the body. The other thing is, we have to look at their work of breathing. They are not going to tell you, usually I'm feeling dyspneic and so on. They have a sort of, 60s, 70s, and they are like, I'm fine, what do you want? So that's what they tell you. So you have to have, monitor their work of breathing and support this breathing, the work of breathing. That is very important, because if they continue to work hard, breathing hard, they are going to injure their lung, and they will turn the mild lung disease into severe form of lung disease, or what we call typical ARDS. The other thing is, we have to have some kind of monitoring of their inflammatory response. Dr. Molla mentioned, some of the CRP, and so on. So in Ethiopian setting, I don't know what we have, but some kind of monitoring is that. So, we may come at a point when we need to tame down the inflammatory response. I know in Ethiopia, a lot of, things are not optional. So I think steroid probably is the one, available in Ethiopian setting. We have to be careful. Steroid in the poor setting, has a lot of complication, including inducing things like, tuberculosis and, other infections. So, but, I think, we have to also cannot ignore its role, because inflammation is one of the mechanisms people have organ failure and organ injury and deaths. So, I think, we have to watch those. So initially antiviral, then at the later force, supporting their work of breathing and, taming the inflammation is kind of the working frame. And coming down to, ventilator management. So I think I have been trying to stress, when the patient is to the point of ventilator, it's really, far. I mean, I think patients, so far from the data, if you see in Chinese, the mortality was, 60, 70. In Europe, it's about, 40, 50%. So, a lot of these patients, even in the very advanced setting, will end up dying. So it's a very late phase. So I think in Ethiopian setting, once we don't have a ventilator, second thing, the ventilator comes not alone. It comes with a bunch of gadgets. It needs sedation. It needs, a lot of monitors, a lot of lines, Foley, NG tube, A line, central line. It needs, a continuous monitoring of the ventilator, and a whole set of people turning around the patient for proning. So I mean, from resource wise, from it's very difficult. So I think our goal should be preventing the patient from getting into the ventilator as much as possible. Once the patient is on the ventilator, we have to make it worth it. What I meant by that is, I think the role of the ventilator is to give the minimal oxygen and the minimally acceptable oxygen to maintain organ function, and probably some tolerance to hypercapnia or high CO2, and to let the lung rest as much as possible. So this is what we call a lung protective ventilation. So as I said earlier, the patient can injure his own lung by breathing harder. And when that lung is even more sicker and unable to sustain the patient, and when we put the ventilator, if we make this ventilator really push hard this lung, it's like whipping this lung, we are going to cause more injury by the ventilator than the benefit. So we have to make this ventilator worth it by doing a protective lung strategy. That means using a small tidal volume. That means limiting the pressure. That means using the lower rate on the ventilator as you can. That means using lower FiO2. So everything you have to kind of keep it on at a minimum, pay. If you see, a O2 sat of 99%, you should not be happy. You should go ahead and decrease the FiO2 so that it will be the lowest acceptable, because there is what we call oxygen toxicity. And, the other, thing is, synchrony and so on. So, it's important to do all of these things. And I think I will stop here and, see if there is any question.
Thank you, Darun. And I know, Ryan, you're driving. You want to say a few words? I can unmute you, and you are unmuted if you want to say a few words.
Okay. Hi, everybody. I guess my few words is listening to everybody's talk. The biggest thing that's even helped us here is really just truly the social distancing. And I don't know how compliant all of, Addis and Ethiopia is about that. But the next thing, of course, we've done is the masks, even cloth masks, homemade masks. We have videos available for how to make them. But I would say those two are my biggest suggestions for how to limit the spread as best as possible. The masks are not a substitute for socially distancing, but of course they're helpful. Regarding the ventilation and the lung protective strategies, Zarin is very correct on that. In our ICUs, there's still a little bit of a debate between should we intubate very early or should we try to wait later in that same effort of trying to protect the lungs. And I don't know, Zarahun, which way your institution is leaning, and Fitsum, I don't know how you guys did it, but that's been something of much discussion in our ICUs. Do any of you guys want to talk about that?
Yeah, so thank you. So, I'm just being called urgently to the operating room, so I am going to step out to see if there is something I can help. But there are three things I want you guys to discuss for the audience. One is, to define a little bit better, who are the patients that can be treated as an outpatient? So when do you really admit them? That's one question. Maybe Fitsum can take a first stab at this, and others can chime in. The second thing is, about CPR in the ICU. So what do you do? And, I know probably Dr. Fitsum can go back in the advanced care planning issue, because that's probably where you have to settle it and make sure your understanding of the patients about CPR is very clear from the get-go. And maybe that can also be re-emphasized in the area of ethical dilemmas and how you cope in your institutions. The third thing I wanted you guys to comment on is, the ratio of physician to nurses in the ICU taking care of COVID patients on the ventilator. The reason is in some of the ICUs in Ethiopia and some places, there are just few beds, 6 beds, 8 beds. So how many nurses do you need? How many physicians do you need? And how do you spare that? So is there a specific ratio you recommend? How, to control traffic? So if you guys can share a little bit more of some specific thoughts about, the personnel composition to take care of these patients. And I really appreciate Zeriun's thought about, the nurses. And I think this is a time where healthcare professionals are really tested in terms of their moral standards, their ethical standards. And I think I think that is what physicians and nurses and healthcare professionals are supposed to do. I mean, do what they can in this kind of, healthcare crisis. And I think we see in all our hospitals, actually, people raising to those standards and beyond. And so I think it's really important to make sure there is a big team. It's not only the physicians or the nurses, it's all of us. However, as physician leaders, we have to really recognize and praise the role the nurses are playing, because they really do play a huge role. And last question, I don't know if you guys are taking notes, is, with the crump coming up in Ethiopia, do you guys think it might become a time of the flu crisis and the pandemics may be ticking up? So as you guys work on this, I know it's 10 minutes to 4 in Ethiopia, but I don't think it's going to be a quick back and forth from the OR. I think I'll be back before you guys finish answering these questions, but I would appreciate if you guys continue to answer these questions. And Malaku, if you can also wait for some more questions if they come. Thank you.
Well, in France, it was all based depending on how the epidemic was going, actually. At the first phases of the disease, we were taking care of all symptomatic COVID patients since we had beds. But as the number increased in our hospital, well, we had 3 main sites, but we filled like more than 400 beds and more than 200 ICU beds. So as the epidemic was increasing, we had to have indications for hospitalization and also to have criteria. So for the indication for hospitalization for symptomatic patients were for those who are population at risk of severe forms, like age over 70 years, chronic respiratory failure, CKD patients under dialysis, or immunocompromised patients, patients with chronic heart failure, cirrhosis, and diabetic patients that with a complicated diabetes, and patients with metastatic cancer. As I said last time, we also had all third trimester pregnant women hospitalized to monitor, to have the obstetrical evaluation. And we had all the patients where ambulatory monitoring was not possible that were hospitalized, because we have a social health care that can allow us this. So the other patients where symptoms were considered non-severe were treated by, we have like a mobile emergency care units who received the phone calls from patients, and based on symptoms, they would refer them to the hospital or tell them to stay at home and be monitored by their GP or by telemedicine. So the main criteria was dyspnea, in order to tell them to go to the hospital. Or for some gastrointestinal symptoms, the criteria would be if they have hypotension or dehydration, they would come to the hospital. Otherwise, anosmia or other symptoms were not referred to the hospital. I don't know if you have other indications of hospitalizations in America. Here, it's mainly gastrointestinal symptoms, severe gastrointestinal symptoms in comorbid patients, or respiratory symptoms, severe and symptomatic patients at risk of severe form.
Can I jump in here?
Yeah.
Yeah, I mean, right now what we've been doing here is we follow the usual criteria for hospitalization. You know, all patients that are feeling sick, they come to the emergency room. Patients who are less sick, have some upper respiratory tract symptoms, myalgias and stuff like that. Oftentimes they go to the primary care, they get tested. When they're positive, they get those antibiotics, Plaquenil, and advised to isolate themselves. when they feel sicker, they show up in the emergency room. So then if they are found to be hypoxic, for example, they are in acute renal failure, hemodynamic issues, usual stuff that led into hospitalization. So that's what generally we follow. And I think to start with, we should probably stick to that in the Ethiopian context, because as we were saying, hopefully that won't be the case, but as the kids grow, the system can be overwhelmed very easily if we take everybody who tests positive for coronavirus. And as I said earlier, it depends on the availability of resources and criteria that's set by the hospital and stuff like that. Because if it gets overwhelming, the system is not able to take care of everyone with this kind of patients. That's one thing I wanted to comment on. The other thing is that someone asked about number of ICU beds, staffing, nursing, and things like that. So I can tell you my experience in here, all the nurses and the physicians. I think we have opened our ICU, new ICU, COVID ICU on March 21. Since then, if I have to say my personal experience, every day we work 12 to 13 hours, and I had only 3 days off so far. So I worked like 28 out of the last 31, 32 days. So it's a usual world, unusual situation, unprecedented situation. So prepare, if that were to come to Ethiopia, God forbid, you need to prepare to work longer hours, longer days, try to have a plan to minimize staff exposure. For example, if there's a COVID, you need a lot of COVID patients, have 1 or 2 physicians and a couple nurses, 3 or 4 nurses, depending on the number of patients, stay there for several days and not take care of another group of patients who are not COVID. Because if people are going back and forth, number one, it's going to be very stressful to don and off when you go in and out of that specific area where COVID patients are taken care of. Number two, there is higher risk of infecting other people and staff and so forth. So we had 42 ICU beds in here initially, but we expanded quite significantly, and we had we made it a 210 ICU in this hospital, and prepared everything. So if you have 8 ICU beds, I think you should plan for example, 3 times more than that and try to mobilize the results soon. And also, plan on working every day if needed, every night if needed, depending on how many resources you have. It's hard to tell that you need to have this number of nurses, this number of physicians, because the situation you guys are in, where it's totally different. And what I'm suggesting is, try to set up a committee, plan ahead, try to evaluate the available resource or the resources that you can mobilize, and how you can expand, how you can respond to a crisis situation and things like that. That's what I can say.
Yeah, the second question was regarding, I believe, your recommendation regarding CPR, as negative pressure rooms are not available in Ethiopia. I know there was that discussion from last week. Any thoughts, maybe Dr. Zarion?
Yeah, so I think CPR is really, I think, a tough area. I think, in my last talk, I tried to mention in Ethiopian setting, if somebody is to the point of CPR, I think I would say it's too late, and I'm hoping that the policymakers would make it clear, unless in a specific situation, it's probably, I think, it's not worth it. It's probably going to be just exposing the staff to the virus. Just thinking out in that setting. But minus that, there are times when we need to do CPR, and I think unfortunately the American Heart Association, recently in the last week or so gave a guideline. So in that, I think they clearly stated that. I think they did rearranged some of the steps we need to do. The first thing is, I think not to, when somebody had a cardiac arrest, we have a sense of rush and we want to run and help people. Please do not rush, okay? Make sure you wear appropriate PPE, make sure, you have all of it and you are well protected. And actually, in my hospital, we have electronic ICU. So somebody's, for example, I work at nights, the last 3, and I am upstairs on the 7th floor, watching, monitoring patients on EICU. Downstairs the fellows are, working, on these patients. So when a code is called, I have a bag sitting next to me. So I start running, and on the way I'm wearing all these things. I'm putting the gown, I'm putting the glove, the first set of glove, I'm putting this, so I'm running, and I'm, at the same time I'm dressing, because there will be even more time needed once I arrive to the door of the patient. So I think so we have to make sure that we have appropriate PPE. So it's good to pre-plan it, to rehearse it in mind, what happens when the code is called, and how to get PPE, and to make sure everyone is wearing well. So that's number one thing. So the other thing is after you go in, you shouldn't immediately jump and start CPR. You should somehow have a filter on the patient's air outlets, which means the best is to intubate first, if you can. That may be possible, not possible, but if not, you have to have a bagging with a HEPA filter at the exhalation port. This is again to limit the exposure to the health care workers. So even actually the best is, if you can't intubate, the best is to have a supraglottic airway, which means things like LMA. You put LMA and then you back through that, and you still, if you have it, put a filter, the HEPA filter at the exhalation side. So I think securing the airway is important, to limit the virus coming out and, all over the room. And as you know, CPR is an aerosol generating procedure. That's the reason why we do that. And then, the CPR, after that, the CPR and so on will continue. So typically, when I arrive to the scene, they are bagging and they are, doing CPR. So, what I do is, our respiratory therapists are getting ready for the intubation. At this point, we don't allow our fellows to intubate. So, it's the most experienced person who does go do that. So I take over, and just before intubation, the CPR will be paused. So until I intubate, the CPR will be stopped. And I intubate the patient, then immediately connect it to, if you have a ventilator, to the vent or to the bag again, and then the CPR will be resumed. That's the thing. The other thing is, we limit the number of people going into the room. And one of the things, again, fortunately we have is, we have expanded our electronic ICU capacity to the ICU or to the floor level. So that means some of the people are outside and watching through the video. Actually, the other day it was very, amazing to see the nurse outside was, directing, go ahead and give epinephrine. She was timing the epinephrine time, the medication time, and so on outside the room with a video. So that gave us a capacity. So, I think if I think videos I don't think they are expensive, if you have them in these rooms, and if you have, Ethiopia can make a way of communicating from outside, I think that can help tremendously, and also help the nurses monitor these patients. They don't have to go in and out. They can see them, through that and talk to them and so on. So that has helped as well. So, if needed, I can send the guideline, but these are some of the changes which come with COVID.
Can I add just one point in this one?
Yes, please.
Oh, Dr. Tafara is back. Good to see you back. So,
Yeah.
so last time we had a very, very good discussion about this, trying to see what we're doing here and what we should do in the Ethiopian context. And what we, to summarize that, even in the best, doctors very nicely summarized how we prepare and how to try to make that CPR safe in the American setting. There was a big discussion, even in big journals like New York Times and stuff like that, that high-level expertise people were recommending not to do CPR even in the American context. If you are at that point already, chance of survival are very limited, even in the Western world. Generally, sometimes young patients tend to do well, but mostly someone is very ill, multiple organs failing, going into cardiorespiratory arrest, chance of survival is limited. If they survive, they end up in nursing home, in this. In the Ethiopian context, I think everything considered, when patients are to that situation, the chance of survival and ongoing care would be very difficult. And what we actually suggested last time is that there should be an aggressive discussion with policymakers, with Ministry of Health involved to think ahead about that, to see if some urgent kind of policy could be made when it comes to that. But given absence of that, I think what would work best is to have aggressive discussion with family and stuff like that, prepare them if someone is declining quite significantly. I think the best way to go in the Ethiopian context is, let family know that the patient is not doing well. And unless the patient is very young, otherwise healthy, all other organs are, working okay, then the recommendation, I think what I would suggest is not to do CPR, because I don't think there's any reasonable chance of getting them around, number one. Number two, given limited resources, there will be too much exposure to staff in the Ethiopian context as well. And the other thing is, as Dr. Sirian said, when something like that happens, even in here, there's a sense of urgency and everyone wants to run in. I always try to remind my staff, you are the most important person in that situation. Make sure that you are appropriately dressed and stuff like that. Actually in our hospital, what we do is we try not to do CPR. If we have to, really, for really young patients, then always we make sure that the patient is intubated. Normally we jump on doing CPR first, but now what we do is always secure the airway, put all those filters and stuff like that before we start CPR to limit exposure to stuff. So, in short, I think it's in the absence of policy, try to plan ahead when patients are declining, prepare family, and generally the recommendation is probably consider not to do CPR unless you think you have a very, very good chance. The patient is like 25 years old or 30 years old, kidneys and everything are doing well, you have a good chance, then you may try it under extremely careful situations.
Yeah, thank you, Mola. I think this is very clear, and also in the last discussions we had, some of these policies have to be institutional policies, and I think in our limited resources, preparing family, talking about talking about the fact that if this happens, it's usually fatal, is I think a very good beginning. So, do you have any crystal ball about the flu season and what is going to happen? Anyone wants to take a stab at it to respond? Do you think it will get worse in the current season in Ethiopia? What do you think? Okay, so nobody's taking that epidemiological guessing. Okay, and then one last question, maybe here to wrap up, is steroid stuff is coming again and again, and partly because I think in Ethiopia for very sick ICU patients we tend to give, particularly in ARDS settings, we tend to give steroids. And I know several thoughts were shared the last time. One of them, if I remember, please excuse me, I'm a surgeon, so I don't use steroids much. One of them is that if the patient needs steroids for some other reasons, to give that steroids, but steroids being used specifically for COVID-related lung issue was not recommended. So that is what I understood from the last discussions. And what are your thoughts? Am I paraphrasing this right, or did I get it wrong?
Gurma Eliasne, let me take this one. I just want to say hi too.
Hi, Elias.
Okay, so I joined you guys halfway, so sorry about
Okay.
that. I was rounding. So in general, I think the discussion was great, and I hope the participants got something out of this webinar series. And I know we're doing some surveys, but I'm excited to hear what they think they got out of this and what they want going on in the future. That would be very interesting, I think. And I was hoping that we can arrange some kind of medium that we can listen what they have to say somehow. It looks like so I know that through the chat we're getting some of their questions, but it would be wonderful to see what they actually got out of this webinar and what they want going in the future. Having said that, let me take a stab at your question. Steroids. So we're learning on the fly, right, on this disease. So a lot of things are changing every week. So I will tell you what we do, and I'm sure everybody's different now. Starting a couple of weeks ago, we have adopted what Yale does, and they have adapted because of some of the experience. Most of the data as anecdotal, so there's no data. But we use steroid in a specific situation, other than what you said. What you said remains correct, because if you have any reason patient to be on steroids, you continue that. But if in ICU patients, when they're critically sick, we try a lot of things. One of the things we do is the monoclonal antibody, the IL-6 receptor antibody. What we have is tocilizumab. And if we do use them, we usually follow that with a short course of steroids. About 72 hours, see if they respond. If they do respond, we tend to continue that. That's how we're using steroids now. And I think a lot of facilities are adopting similar indications. Knowing that steroids, one of the fear of steroids is, of course, it does continue the replication of the virus. That was the fear. And again, I just want to remind people, we were afraid not to use steroids because there was no data. It's just because of the experience from the prior SARS ones, especially 2003, because from that experience, there was some more high mortality on people that use steroids. It was marginal, but because of that data and because of the high replication, the earlier recommendation was to avoid steroid if possible. But now I think people, again, a lot of things change. Now we're not using hydroxychloroquine like we used to. Everybody was on first jumping on it. Now we're seeing not really a lot of benefit in ICU patient at least. So that's one of the changes.
No, thank you, Elias. Zariun, do you have anything to add, or Mola, anything to add about the steroids?
Yeah, so I think as Elias said, it's it is a similar fashion. So I think many things in COVID are really a clinical judgment. I think as long as you are really keenly seeing the patient and evaluating the progress and all the data points, then you have to make a judgment many times. So I think ventilator, when we say, for example, not intubating, it's a very fine line. Delaying intubation is dangerous, and so it is a call. So you have to really bring your clinical judgment, or you're being physician to that. It's the same way for steroid. I mean, for steroid, I think you can follow things like inflammatory markers, but you have to assess what's causing the patient injury. Is it the virus? Is it the patient himself? Or is it the inflammation, the unregulated inflammation. So if it sounds for you the unregulated inflammation is what's causing the patients have that high inflammatory markers, toxic natures, despite antivirals and so on, other organs are failing, then I think you may pull the gun of steroid. Again, in Ethiopian setting, we have to be careful. The problem is, steroid suppresses the immunity all across the board. So, it can expose you to other infections, especially in Ethiopian setting. Tuberculosis is the feared one, because most people are exposed to tuberculosis that can flare up easily. So the Infectious Disease Society of America, recently also came out with a guideline saying that, they are not recommending for it. They are not recommending against it. They are accepting it as kind of in a research or setting. So it's this COVID caught us in surprise. Nobody knows what to do, but I think there is a role for it. So again, I say you have to use your clinical judgment in that setting. Another, I think, question probably at the same time I could answer is, the TB answer is, the fibrosis is, again, I see there, fortunately, I had the first patient, my first patient was a patient with pulmonary fibrosis and who has COVID on top of that. And, I intubated her. Unfortunately, she died in a couple of days. Those patients do not do well. They really succumb quickly. And, I think once I intubated her, immediately the kidneys, the liver starts to fail and, continues to decline. So fortunately, we were talking to the family early on and we made her DNR. So we didn't have to, CPR and so on. So I think those patients don't do well. Thank you. Okay.
If I add a little bit from our experience from France for steroid.
Sure. Yes, please.
So we had a very balanced also attitude for steroid usage, so utilization. So if it was on a critical patient, the recommendation was to include the patient on clinical trials. But if we had the idea of putting them on steroids, it was recommended not to put them on steroids the first week of the symptoms. And we had strict clinical criteria, oxygen requirements, and the increase of oxygen requirement within 24 hours. And after excluding heart failure or other differential diagnosis. And if we had a compatible bilateral lesions, we could give corticosteroids. Actually, we are investigating, we are doing a retrospective study to see what happened to these patients. We didn't wait until they went to the ICU for some patients. We just gave it to them when they exceeded the requirement of more than 3 liters per minute of oxygen to have a saturation of more than 94%.
Yeah, so moving target, I guess. So I think clinical judgment, as usual, is going to be the critical piece. I just want to be very sensitive about everybody's time again, and I just want to say thank you to our panelists who have spent another really amazing hour with us. So a lot of thank you for Dr. Zerihun, Dr. Putsum, Dr. Mola, and Elias, and I thank also Mel, who is in the background, really making this happen. So until we see you next week, and have a safe weekend, and thank you for being here, guys. Take care.